Hi, it's Dr. Noel Williams, Optimal Health Associates, Oklahoma City, Oklahoma, June 30th, 2020. I want to be very clear, Optimal Health Associates is an independent practice. There's occasional people who either I work with or know me or have to be in the same medical community type things I'm in who are not particularly endorsing of anything I've said about COVID and have communicated they don't want any association with me. So we're Optimal Health Associates. There's a couple other doctors, a bunch of PAs and nurse practitioners. They're awesome people, and we take care of lots and lots of folks. So this is the COVID update. So lots of stuff happening with COVID. Again, big numbers, 41,000 new cases today reported from yesterday. We're averaging over 40,000 cases in the United States a day, 40 to 42,000. The Fauci said could hit as high as 100,000. We'll talk about that. Oklahoma, 565 new cases yesterday, a big day for that. We have 300 in the hospital, which is about as high as we've gotten. We're at, I think, 375 deaths to 380 deaths. Long term, we were predicted to hit 600 by August, and it looks like we may actually get there now, unfortunately. I was hopeful. And remember, if people have been watching for a long time, one of my caveats to limiting the death rate was the adoption of hydroxychloroquine, which we're going to hit on pretty hard tonight because of just some more data. But again, that wasn't adopted. It was universally derided by every major medical organization, the FDA, CDC, NIH, American Academy of Cardiology, all of which have been criticized at length by scientists for completely providing invalid information. But that's what happens when there's political agendas. So we'll get to that eventually. So when you're looking at the makeup of who's getting COVID right now, the average age is about 37. The death rate in people who are in their upper 30s is about 0.08%, or about 1 in, I think, 10,000, if I'm doing that right. Because 0.1 would be 1,000, 0.01 or 0.08. So somewhere between 1,000 and 10,000. It's a small number, and it's probably much smaller than that in reality. But the thing we have to know is these people who are in their 30s or 20s who get it can spread it to older people, and that's the big difference again with kids. And we'll dovetail into kids for a second because schools should reopen in the fall. I want to be completely clear about that. If you're a middle schooler or younger, you can go to school. The teachers don't have to worry. You don't have to worry. Okay, you're not going to get it almost ever. You're not going to get sick if you get it almost ever. There's a ton more things to be worried about than COVID, including flu, riding your bike in the street, anything you can name if you're under 14. And that's the data. Younger people don't spread it. They're not going to give it to kids. They're not going to get it from, or they're not going to give it to teachers, and they're not going to get it from teachers. Now, high school students, when they get to 17, 18, definitely have some ability to get infected. Now, again, infected in a way that they could spread the virus is what I'm talking about. People can get infected at any ages, but to actually become more infectious, symptomatic, and maybe potentially infect someone, 17, 18, 19 definitely starts to kick in because you start having some ACE2 receptors in your lungs, which we'll get to again. So once we're over 18, there's going to be a little more transmission across a group. And that's why these people 18 to 30 going to bars are popping everywhere with the virus, but none of them are getting particularly sick. It's just they have the ability to spread the virus to others, and that's the thing we have to remember about this. So when we look at Oklahoma, big news today for Governor Stitt. None of it positive. 565 new cases. Casey Schrum and Gerald Loffridge, the two secretaries in charge of the COVID response on a state level, both resigned. They did it in a very organized way. They had replacement people already brought in, but again, the person replacing Casey Schrum isn't a doctor, does not have is not medical really at all. She's sciencey, but that's it. And then a health department took over for Secretary Loffridge. So again, we're going. And again, not a personal criticism of the two people who replaced the two we had, but again, we're kind of going into the trough of the bottom of the barrel of people for quality in terms of qualifications to be the people to help the state in this with knowledge base of stuff. Now the person Corbett replacing Loffridge has definitely experience. The other person just doesn't have any in this, so it's kind of a joke. But they stepped down. Why did they step down? Well, they, of course, said they wanted to go back to their normal things. Well, you know, different people hear different things. And the thing that, I heard was since Stitt won't listen to anything they say at all, and the cases are skyrocketed, they were out at that point. They don't want their name associated with COVID in the state of Oklahoma as the people who are supposed to protect us, because it's failing. So that's why they resigned. And that's what I'm hearing from the medical circles. And the medical circles are people who know. So, that's how it goes. So in Oklahoma, what can we do? Well, we have to shelter in place if you can. I don't think you want to be going out all the time if you don't need to. You absolutely need to be wearing a mask. You absolutely need to be washing your hands. Those are the core stuff with the zinc and with the vitamin D and with the multivitamin, as I've talked about. But there's some other stuff we're going to get to, because we got to get into reality now. Everyone's going to get COVID. Like I've unfortunately been saying, we are going to be exposed. We are going to get it. And there needs to be a plan for each person. And we'll get there in a minute. So then at a national level, Fauci going that we could get to 100,000 cases. I again want to illustrate this is the complete and total failure of the FDA, CDC, and NIH. I mean, his solution, we can wear masks now. That's all. Everyone should wear a mask. This is the guy who told us for weeks masks don't work, which again started the whole thing that masks don't work, and why we're stuck in this ongoing silliness about people who don't wear masks and don't understand that they're both can protect you from spreading it to others, and it's going to have some protection for you. Now, the key thing with masks is when you're taking it on and off, it'd be nice to clean your hands. That's smart. You're bringing your hands by your face. Your hands can have germs too, so it's constant hand washing, and wearing your mask is going to help. But again, that isn't the solution. That isn't the solution. Everyone's going to get it eventually. It's just trying to spread it out. So what's the solution? Coming. I'm not going to tell you yet. So then let's talk about Oklahoma cases. So we have 300 people in the hospital. I was on a conference call for that this morning. 80% of the people in the Oklahoma City area who are in the hospital are of Hispanic origin. So unfortunately, the tendency for COVID to strike minority groups, people who are less nutritionally repleted, again, is occurring in our community. And so we really need to, again, be supportive to all of our members of our community and encourage them to take vitamins and eat nutritiously, which again, people don't do, which is why they get sick if they're not just old and debilitated. So that's the thing, that's the problem. We'll see what happens with the death rates. Classically, again, with probably about 300 people in the hospital, you'd expect about 100 deaths to 120 deaths. Maybe we'll do a little better. The case is some of the people are younger, and so that's a positive. We also have the steroid use now. Our doctors in Oklahoma, the critical care infectious disease hospitalist people, whether you're at Saints, OU, St. Francis, we have high quality doctors really focused on this, and nurses and respiratory therapists and support staff who are just doing everything. And we really need to pray for those people too. We've had documented 485 healthcare worker deaths from exposure from caring from COVID patients so far in the United States, which is a significant number. It's not like Italy where they hit well into 1,500 plus or something. But again, things we need to be aware, and we really need to be kind to our first line people, and don't ever neglect to say thank you if you know someone who's a nurse or a respiratory therapist or anyone working at one of the big hospitals, and tell them you appreciate them, please, because they are putting their lives at risk for our community, and that's very important. So let's talk about what we really need to do. What do we really need to do? What I think we need to do, and a lot of much smarter people than me think we need to do, is we need to really get hydroxychloroquine going. I had said before that I didn't think our deaths would go over 80,000 if we adopted hydroxychloroquine. We did not. It's political. It's utter nonsense. And that's the issue. If we put everyone who gets exposed and everyone who gets it or who gets COVID on hydroxychloroquine, the death rate's going to plummet. And there's another article that just came out, which I'm going to read to you parts of it, and I'll post this article. It's from a journal of pharmacology. So one of the things to keep in mind is what happens with SARS is it has this protein spike. It's the S protein that sticks out. It's a finger going, I want to infect you. It binds to something called the angiotensin converting enzyme 2 receptor in alveolar lung cells and other places, but the lungs notably. So that's genetics and age. So Y chromosomes give us more as guys, and they start to kick in our 20s really and go up, 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 up. Girls, slower rise and always a much lower number, okay? But that's why really the incidence of more intense disease goes up in the upper 20s because you start to have more ACE2 receptors. Well, as it turns out, how does hydroxychloroquine and chloroquine work? Well, they interfere with the ACE2 receptor's ability to be bound by the S protein. So if you can't have the S protein bind, you can't get infected. So that's the mechanism of action. We even now know the mechanism of action pretty exactly on hydroxychloroquine and Plaquenil. The other thing, so when you take hydroxychloroquine, it turns into chloroquine. And so the other thing, that's a chloroquine effect. The hydroxychloroquine does something a little different. It raises the pH of what we call endosomes. So exosomes I've talked about, they're little lipid bubbles that contain messenger RNA and proteins and stuff. Endosomes are kind of similar, just bigger. They change the pH, hydroxychloroquine changes the pH of endosomes that have infectious particles, and so that deactivates them. So that combination is very important. So when we look at this article, which I'm going to read some quotes to and I'll post it pretty immediately, there's some things to know. And so I'll start with this. Chloroquine phosphate inhibits terminal phosphorylation of ACE2, and hydroxychloroquine elevates the pH in endosomes, which are involved in virus cell entry. So the virus getting into the cell, the endosomes go bunk and get in. So both mechanisms constitute relative antiviral mechanisms of chloroquine and hydroxychloroquine, period. In vivo, so in the body, hydroxychloroquine gets converted into chloroquine. So now let's give you some studies. It was demonstrated that concentrations of hydroxychloroquine recommended for treatment of SARS-2, which is COVID-19, infection comprised an oral loading dose of 400 milligrams twice daily at day 1, followed by an oral maintenance dose of 200 milligrams twice daily for 4 days. These results were deduced from in vitro or study data of infected cells. A recent pilot trial conducted in more than 10 hospitals in Asia with more than 100 patients with COVID-19 disease demonstrated that treatment with chloroquine phosphate is superior to control for a variety of the disease stuff. But now let's give you some specific stuff. Chloroquine phosphate should be administered as a daily oral dose of 250 until clinical convalescence. So let's talk about chloroquine. We don't use chloroquine, but again, in the studies that showed chloroquine was harmful, how much were they giving? 700 milligrams 3 times a day. Okay. They were giving 250 milligrams of chloroquine in China and knocking the disease out. You give 2,100 milligrams or even 700 milligrams, there's tremendous side effects, which is why the studies failed, which was why the guy at the FDA got nuked by Trump, who was in charge of the studies. It wasn't because Trump was grinding an axe with him for some other reason. He was making sure chloroquine and hydroxychloroquine didn't work. So a recent open-label, non-randomized clinical trial conducted in March in France with 20 COVID-19 patients treated with daily 200 milligrams hydroxychloroquine for 6 days demonstrated at day 6 a negative viral load in 57% versus 12% in the control patients. So a 500% or improvement in response versus doing nothing. statistically significant. In a randomized clinical trial conducted in February in Wuhan, 62 COVID-19 patients were randomized to the hydroxychloroquine or Plaquenil for 5 days. Improvement in absorption of pneumonia, as analyzed by chest CT at day 6, was observed in 80% of the treated patients versus 54% in the control group, which were untreated, and again, statistically significant. The results from these small studies therefore strongly suggest that hydroxychloroquine has therapeutic efficacy in COVID-19 disease. And it goes on to keep on talking about that. But the point is, you have the Yale data, you have, and Harvey Reich, you have studies, all these different studies popping showing benefit. But we won't mention that here in the United States by any mainstream news organization or by the FDA or CDC or NIH, because they would rather we got sick and died. Okay, so the key thing is, if you get exposed, you get on Plaquenil, or if you get infected, you get on Plaquenil right away for 5 days. If you don't respond if you're not turning the corner within 2 days, then you're a candidate for, I would add the Z-Pak then. The problem people are going to have is getting someone to write it for you, because doctors are generally scaredy cats, and there's so much negative pressure on us. You can't imagine with the COVID stuff. You can't imagine telling the truth about stuff now. It's incredible, the negative you get from your colleagues, and then the community at large at times. So a lot of doctors will not write for it. So you need to find someone and be in their practice. In order to have COVID treated, you have to already have been in the practice. And so get in a practice where someone will write for it. Call around, figure it out. If you're not in Oklahoma City, if you're part of our practice, we can write for it, but you have to be part of our practice already. If you're not in Oklahoma City, and there's other people in Oklahoma City who will write for it too, you just have to call around and figure out who it is. If you're not in Oklahoma City, ask your friends, ask relatives. Do you know a doctor who will write for it for you? Because you need access to Plaquenil if you get COVID-19. It's a 5-day course. It's going to be incredibly tolerable. As the data shows, the cardiac side effects with Plaquenil is about 1 in a million. If I give you aspirin for 2 weeks, it's more dangerous. So there's a variety of things that are infinitely more dangerous we do routinely in medicine for medications than Plaquenil. So again, that's what I would encourage. But it's about the Plaquenil. It's the solution. Everyone's going to get COVID over the next year. Maybe there'll be I'm sorry for the ums. My brother Jeff in California is like, you too much when you're talking. I can't help it.
It's followed by an
So anyway, so this is a long post, but it's live. So that's what you got to do. You got to get a Plaquenil prescription and have some, just in case, and then have it coordinated by a doctor. That's what I would do. That's what we do for our family. That's what I do for my patients, and that's what you need to do, period. That's your solution, and I don't think anything else is going to replace it or be easier to deal with than that. So that's kind of the summary of what I'm going to talk about. Kim has some questions for me because people have questions, and I haven't really been looking at questions the last few weeks because I've been a little bit overwhelmed with stuff. So go ahead.
Okay, so how do you currently feel about antibody testing? Has it gotten better, and what about all the different kinds?
The antibody testing we're still not recommending until David Chansom, our infectious disease guru here in Oklahoma City, says, Noel, use this test. I am not going to order one because he has not found one that he feels comfortable recommending scientifically, and he knows his stuff.
Okay. Several different turmeric questions. One about absorption, interaction with migraine meds, and how much turmeric should you take for COVID reasons?
Well, so turmeric is just a massive natural anti-inflammatory. The issue with turmeric is absorption. It takes a lot of turmeric to get a serum level, and classically it's 3 grams of turmeric twice a day. No one can do that. I wouldn't say that, but very few people can do that. I tried to do that much turmeric many, many years ago and had just tremendous GI upset. And when you're already doing zinc, adding turmeric can get a little bit hairy, I think. So what we always encourage people to do is use something called Meriva. Meriva is a product from originally Italy that's just 250 milligrams of turmeric, but it's mixed with something called phosphatidylcholine. It's a phospholipid. Phospholipids are what are on cell membranes. So when you have that in your gut, it's going to absorb right through those gut cells, the phosphatidylcholine, and it will pull 250 milligrams of turmeric in and make it give you the absorption of about 12 grams of turmeric, only taking 250, so you don't have side effects. It's also equivalent to an IV dose. So that's a product that you can get online. We carry it in our store. It's a Thorne product. Thorne Pharmaceuticals is an excellent pharmaceutical company. We carry a variety of their products, but they are also online, so you don't have to go to our store. You can just get them. But just one a day would be usual for anti-inflammation maintenance. We go to 2 a day for people who are in cancer treatment because it also augments chemotherapy and radiotherapy outcomes and prevents side effects. And someone with a very strong family history of cancer will do twice a day. But other than that, just once a day usually. I don't use any other kind of turmeric than that. Period. Adding pepper or piperine doesn't do anything to the absorption really. That's kind of a made up homeopathic thing. Sorry, it does minimal, and it's still going to upset your stomach potentially. So we just use Meriva as the gold standard. There's probably some other phosphatidylcholine products or nanoparticle type phosphatidylcholine products, but I can't keep track of all of them, and so I just use the one that's been the gold standard.
Is ibuprofen okay at this point to take?
Ibuprofen, I think for younger people is okay to take. I think for older people, there's still just questions about ibuprofen and its interaction with the COVID virus, and I would not feel particularly comfortable in people much over 35 using Advil for flu symptoms, or really over 30 for flu symptoms right now. I think you want to use Tylenol, and if you an aspirin's fine, but there's just some stuff with Advil we don't know, or ibuprofen in people over 30 that we have to worry about. Now, if you're under 30, I don't think it's a big deal, and if you're a teenager, who cares? And again, remember, children shouldn't take aspirin after a viral illness or with a viral illness under any circumstances, because they can get Kawasaki disease potentially. There's a potential doubling there with that. And Kawasaki's the rash and inflammation, and there's some theories that aspirin can contribute to that in children. So Advil in children, no Advil in adults, really.
Okay, and then is there any reason not to take melatonin during the day? Somebody said they were having an adverse, like the opposite.
Melatonin, if it doesn't make you sleepy, you can take it during the day. And there's always people who are opposites. I mean, we use natural progesterone a lot. It makes most people sleepy, but every now and then it's like, whoa, it made me awake. So no, that person takes it in the morning. If melatonin makes you wakeful, take it in the morning. It's fine. In terms of maintenance, 1 to 2 milligrams a day is fine. If you want to do more because it helps you sleep, it's totally great to do more. We kind of max out our dose most of the time at 10, but we will go up to 20 milligrams of melatonin in some people as a surrogate for trying to increase, as a mechanism to try to help with human growth hormone stuff. But for routine use for COVID, it's somewhere in 1 to 2 milligrams at least a day.
Okay, so with more and more positive numbers, do you think that's going to mean less of a second wave?
No, not at all, because the number of positives is minuscule compared to the number of people. So if we look now at the total number of positives in the United States, let's make it 3 million instead of 2.6. Let's multiply that times 10. So it's 26 million people, and let's round it up to 30 million people. That's still only 9% of our population. And while that's a significant number, herd immunity kicks in at 70% of the population. So the second wave is still going to be more intensive based on our current trends. Now, if we go to 100,000 cases a day in the next week or 2 or 3, like Fauci says could happen, and we then end up getting another 5 million cases by September 1st, and you start to add the 5 to the 3, 8, and we're at almost 80 million cases, that would have an impact potentially on the second wave, because we're at a 30% incidence or prevalence in the population. But at our current rate, I don't think it's going to impact the second wave yet. We'd have to have a lot more cases in the immediate short term. The second part about that is, too, we do expect there to be more mutations with the second wave. That's just kind of normal as that happens, and we have to see, are we going to get lucky and have weaker mutations, which you have to keep in mind can happen. It doesn't always turn into worse mutations. I mean, Spanish flu, it was a worse mutation. That could happen with COVID, but there's no predetermination that it always gets worse. It could just as easily lessen in intensity. It could become more infectious and be less intense. It could become more infectious and be more intense. It could become more infectious and be the same intense. We just don't know. But there's no reason that it has to get more intense. It can mutate less intense. And so we can always keep our fingers crossed.
A couple more. On testing, on the numbers that we have that are positive, some people are testing multiple times because they have to in order to go back to work or whatever, to wait for the negative test. Is that skewing the numbers that we're seeing of positives? Because it's the same person testing several times.
If they're doing so the question is, if someone's like, we have someone not in our office, but a relative of someone in our office who has tested, I think, positive 3 times subsequently to his initial test. He's not clearing it. It can take, and he's probably not even vaguely infectious, which is the tragedy, but he's not allowed to work because of that. No, that should also just count as 1 case, not as 4 cases.
Is that how
they're supposed to be counting it that way? Because the case is associated with, the positive result is associated with a name and a social security number. So no, they should not be counting that person twice, but all the statistics are screwy. Everybody's lying about it in the government. They've done that everywhere from Florida now in Houston, so who knows? Who knows?
Okay, and then one question about zinc. Do you know anything about it lowering glucose in diabetics?
No, I do not, but I'll check. The zinc lower glucose in diabetics, I have no earthly idea. I've not seen any papers on that. It does have a lot of GI effects in terms of stabilizing GI function and stopping diarrhea. And we've always used, again, hair follicles, all about hair follicles. But I don't know about diabetes. I'll do a literature search.
Great.
All right, well, that was a very long post. I hope it's helpful for those of you who managed to last 28 minutes. Anyway, thanks very much. Be safe and look really hard at the Plaquenil data I'm going to put out again. And remember, it's not my data, it's science data. It's peer-reviewed journal articles. And notice all the positive data on Plaquenil, none of it's been retracted, where the negative data on Plaquenil has been retracted. So enough of that. Good night.